Okay, let's get started. Hi, everybody. Welcome. We are glad to have you here with us today, and we're here to talk to you about how to do research in your care at home programs with or without formal training. There are two of us talking to you today from Best Buy Health's research team. My name is Juliana Pugmire. I tend to go by Jules, and I'm here with my colleague and friend, Nicole Zaradka. Nicole's background is in engineering, and she has her doctorate in biomechanics. She was on a traditional academic path in a research position at the prestigious Johns Hopkins University, and there she used commercially available devices to take better measurements while patients were at home. She tied these measures to clinical trajectories, measuring the healthcare value of those programs, very similar to the research we do here at Best Buy Health. I have my doctorate degree in epidemiology and biostatistics. I did the Peace Corps in Zambia and have worked in the Philippines and Ethiopia with the World Health Organization. I moved to the United Kingdom in 2015, and before joining Best Buy Health, I worked at the University of Glasgow in digital health and behavior change interventions and randomized control trials, which has translated to my work with Best Buy Health. While both of us are formally trained research scientists with doctorate degrees, we believe there's scope for doing some types of research and evaluation, for being curious and asking questions and gathering data to answer those questions that doesn't require formal qualifications. There are many methods that can help you understand the impact of your care at home models. So we'll walk you through how we approach research and evaluation at Best Buy Health, share some tools and examples, and hopefully make research feel a little less intimidating and a lot more useful. As we go, please feel free to drop questions and comments in the chat, and we will take a look at these closer to the end of the session during the Q&A. So, Nicole.
Great, thanks, Jules. As Jules said, my name is Nicole Zaradka, and I lead research here at Best Buy. I think it's important to share a little bit about Best Buy Health for those of you who are less familiar, to have a better understanding of why there's also a research team here. So let me set the stage. Best Buy Health partners with health systems, health plans, pharma, and senior living facilities to enable care at home experience across the continuum. Next slide. And the mission is to enable care at home for everyone through technology and meaningful connection. And we do this in a myriad of ways. We use our established infrastructure, our tech expertise, our consumer access to healthcare to provide viable solutions to organizations that are interested in making home the primary site of care. We also have services that wrap around our products like clinical monitoring service, supply chain and logistics support, in-home Geek Squad support, and 24/7 tech and clinical support teams. And these offerings provide an enterprise solution that enables our partners to deliver safe, cost-effective, and scalable care in people's homes. But how do we know that they're safe, cost-effective, and scalable? Next slide. That's one of the things that the research team does. Let me take a step back. Best Buy Health created an internal research team because they understood that high quality evidence is important in healthcare. Now, our group is a mix of professionals with formal research training, and our goal is to help prove how well these care at home models work clinically, operationally, and financially. And we do this by collaborating with our customers to measure the impact of their care at home programs that use our different offerings and then publish these outcomes in scientific journals and academic conferences. And when we think about value and impact, we look at 5 main categories. We looked at shifting the site of care and some of the costs associated with that. We look at clinical effectiveness and safety. Is the care at home programs producing the same, if not improved outcomes for our patients? What's accessibility like in these types of programs? Do we reach a patient population that's maybe more geographically dispersed. What's the administrative burden associated with these programs, and how does our tech potentially increase efficiencies? And last but definitely not least, the patient and caregiver experiences in these programs. Now, we believe if you can impact one of these categories while the others remain consistent, you're making a meaningful difference. If you can start to impact more than one category, we're having real impact. Um, Next slide. And so you might be thinking, like, I already know that our program works. Why do we need research? And the reality is that anecdote and beliefs aren't enough. If you have a program that you want to improve, scale, or even secure funding for, you need data to back up your success. And while formal research lives in journals, and maybe that's not your end goal or why you're on this call, the same methods can be used for internal program evaluation. So the first step that you'll need to take, whether you're doing more formal research to publish or an internal program evaluation, is understanding what evidence exists for care at home models and what others have already found. So Jules, can you take us through some of the work that already exists today?
Yeah, thanks, Nicole. So in looking at the broader state of care at home research, we can see that generally outcomes are just as good as they are for in-hospital care and sometimes even better. We know that people tend to be more satisfied in these programs, that their quality of life is higher, and that costs are shown usually to be less than inpatient care. We still see a lot of variability, especially around patient selection, like what kinds of patients are selected into these programs to begin with. We see variability in the readmission rates for people that are in these programs. See a lot of variability in the outcomes that are both measured and reported in the literature. And this is a big reason why your own data are so important. So if you want to explore existing evidence or refine your questions, AI tools are increasingly available to help us. So things even like ChatGPT can help synthesize information quickly. So we are going to do a really quick, easy example. So I'm going to ask ChatGPT, what tools can help me write a research question or literature? Literature review. There we go. We're going to pop that in. It will always give like a sentence back, and I'm sure most of you have already interacted with ChatGPT, so a lot of this will probably seem really familiar, excuse me. So, okay, first they're giving information about the frameworks. So PICO, like who's your population intervention comparison outcome? I've used that for years. They have some other criteria for setting up your research question. I love that number two is ChatGPT, just like we're doing right now. So that's delightful. So this can help brainstorm questions and ideas and almost have a dialogue. And they give an example here. And so for writing a literature review, so they give you tools like for citation and reference managers. So we use Zotero on the research team. And university settings, I've definitely used EndNote. We like Zotero because it's free and open source. And they give some visualizing tools here to help connect ideas. And then for the AI assisted literature review here, you see elicit.org, and our research team really likes elicit. So we are going to do another quick example here. I'm going to bop over to elicit. They have a free version to use, which we are in now. And I am going to ask for a summary of the current state of evidence for hospital, at home, or virtual ward, because sometimes they're called different things. And I'm going to say in the US, and to identify gaps. So one of the things that's kind of fun about Elicit is that it will give you an assessment of your question here. And now thinking this through, I should have given a really bad question and seen what kind of advice it gave. But it
I
will
also
all
love that you say it's fun. I think it's fun relative to us. Hard to say if it's fun for the audience, but this is fun for us.
That's right. We've come to our careers rightly. It also always gives recommendations about how you can strengthen it or make it more specific. And you'll see here, you can hover over these tabs. So one says specificity, and it gives examples of how to make this question more specific. There, you can make it more about methodology. You can make it more, you can change the population. So here examples could be, do you want to look just in the elderly population, in chronic disease patients, post-surgical patients, for example. So I love that about Elicit, that it gives you some ideas. We also love that there's a fast option. And so this in no way would be what we were going to do if we wanted to publish or really get an in-depth knowledge of the literature. But as a first pass, this can save so much time. And so it gives you first an abstract. It will also generate a report. So it's still working here. It's gathering papers, and you can see that it's still putting this together. So it's estimated that this will be about 3 minutes. I knew it might be a little bit of time, so I was sneaky and I did this in advance so I could just give you an overview of what the output looks like. So I'll just start here from the top. So it will show you your question, it will give you an abstract, and then the methods here are pretty transparent. So it will tell you we analyzed 10 papers from a pool of 50 that met this research criteria, how many screening criteria that it uses, and then it gives you the characteristics of the included study. So this makes it really easy for you to start looking into these papers and getting more information. Another arguably fun activity, depending on who you are, and it will synthesize the information a few different ways. And at the very end, it will give you the references that you can also link out to. We think this is a fabulous tool. It can be either a new topic that you want to learn more about, or even if you know a lot, this could be another option just to see if it's picking anything up that you haven't picked up in your own literature searches. So we'll head back to the presentation, and I'm going to hand back to Nicole.
Yeah. Thanks. You know what, Jules? Like, demos can be funny, right? Because it's like sort of watching somebody write something out. But I really appreciate you just showing that even going to the website doesn't have to be intimidating. The output isn't intimidating. It's easily digestible. And all to say, like, as more and more tools get developed, to make accessibility of information easier and digestible, it's they're just, don't not use them because you're intimidated. That's what I guess that's what I'm putting out there. There's a lot of different things to try. Elicit is one of them, and it's a great resource. All of these AI tools are great resources to get somebody started, especially if your first question is, where do I start? So now that you've got a little flavor of how you can find out what already exists, and maybe that's some of the questions that already exist that have been answered by other groups, and maybe you want to answer those questions with your data. Maybe that's finding out what questions already exist so you can find out what questions haven't been answered yet. The next step is, how do you come up with questions for your program? And what I do, and what we do with our customer collaborators, is we ask, what are we curious about? And what do we think we already know about the program, but maybe haven't proven it out with data? So maybe that's program goals, whether that's this program is meant to reduce readmission rates. Well, how do we know? Like, we think we're doing it, but if we're not measuring it, we don't actually know definitively that the thing that we're doing is working. maybe it's cost, safety outcomes, etc. And so when I think about crafting questions, there's sort of two parts to it. There's the content and then there's the context, and both are really important. Next slide. So when we think about the content, we're thinking about, are you asking questions that test your assumptions that you already have? Again, that could be we're reducing readmissions. That could be that the patients will be adherent to whatever tools that are being used in these programs, or to the interventions we're asking them to engage with, or that the intervention is actually changing a clinical outcome. That's another assumption that we might be making. The second type of content we could be asking about is exploring topics that might impact your program. So new factors that are introduced. Maybe that's a new tool that you introduced to your program, for example, an AI tool or changing a workflow. Asking questions about that will let you measure, again, some of your assumptions, but also how that tool potentially is impacting other parts of your program, because most of these things don't live in isolation. They sort of live in an ecosystem. And then the second part is the context. Um, are you describing something about your program? And so sharing results about how to do something and what to expect is really meaningful, especially if it's not been done before. And so sometimes when tools are new, and they haven't been used in a program before or as part of standard of care, there's not really a good comparison to be able to be made. But that doesn't mean there's no value in reporting what you're finding in this particular program. In fact, that's kind of establishing a baseline, if nothing else. The second way that you might present the content is framing your question as a comparison. So comparing your program to maybe what standard of care is. Now, comparisons are comparison questions are high impact, but they can also be really tricky. And I say they can be really tricky, and Jules will elaborate on this a little more, but they're tricky because the metrics that you choose to measure that impact need to already be measured somewhere else for you to make that comparison. And so creating comparator groups is not quite as easy or readily available as you might think it to be, or as we would hope it to be. And so again, Jules will get a little more into comparator groups and some of the data elements later, but Jules, I'd love to hear sort of your experience, or an experience you've had when working with some of our collaborators in crafting the right questions for their programs.
Yeah, sure. Thanks, Nicole. So we worked with a hospital team, a group of highly motivated clinicians that rolled out a novel virtual ward program. And they ran this program for 2 years. They had data from almost 2,000 patients. Like, it was sizable. And they were very passionate. They were very good at what they did, what they do. And they thought, like, they really believed, they had a lot of assumptions that their program was working well. But we need data to prove this, right? So there's a lot of things we can think are working well, and then that isn't always backed up by the numbers. So we worked together to look at data to answer a number of questions. So one of their beliefs, one of their assumptions was that their enrollment was increasing over those 2 years as they did outreach and got more and more specialties to refer patients into the virtual ward, as they got clinicians and healthcare providers to buy into this idea. So we looked at the average daily census and found, in fact, that it was scaling up at a really nice upward trajectory. They also believed that their patients were adherent to the device technology that was required for them to receive their care at home. And fortunately, the current health platform that they used for enabling their virtual ward has adherence to device metrics baked in to the program itself. And so we were able to pull those data and see if they were prescribed wearing the wearable that is a remote vital sign sensor for 24 hours a day. We could say this person wore it 97% of the time or 57% of the time. And we could do that also with the blood pressure cuff. Were you asked to take your blood pressure once a day or 3 times a day? We could calculate adherence to that measurement, a scale to step on, or a tablet to answer surveys, which could be used for symptom trackers or also experience and satisfaction measurements. So we saw through those adherence metrics that they did have patients that had really high adherence to the devices used in the Care at Home program. They also believed that patients loved this program. And so there were a lot of data to get through to assimilate. And it was kind of triangulated. We had long text answers, we had short text answers, we had validated questionnaires on the ease of use for the technology. And in looking at all these different data points, we could see that for the most part, they were really happy about it. And we also looked at the feedback that wasn't positive to look for opportunities to improve. So, just returning to that idea that Nicole was talking about of framing the question, those metrics I just described were really about the program, is describing the program. Were patients adherent? Were they satisfied with it? Was enrollment increasing? We also looked at clinical outcomes like length of stay and escalation back into hospital or emergency services. And these are often reported in other papers. And they are also known for inpatients within the hospital. So we could see that they were good outcomes compared to the standard of care in this case. Two of the things we really wanted to evaluate, and they were quite keen to evaluate, was the 30-day readmission. And those data were just a little bit too hard. Like we didn't have the time and the resource to comb through electronic health record to get that for this analysis. And the other was economic impact. They were really convinced that this was a more economical use of hospital resources, that it saved money. Not only were patients happier, but it was more cost effective. And we just simply didn't have the data to say that for certain. So that is also part of the process, finding both the answers and the gaps.
Yeah. Hey, Jules, we have
Yeah.
a Q&A question.
Oh, great.
So the question is, what is the largest scale of these home programs that you're aware of? Hundreds, thousands of patients? Um, that is actually
Mm.
not as straightforward of an answer as it might seem, because they're sort of the higher acuity um, care at home programs, which have much smaller census than those with chronic condition management types of programs. For that example that Jules was just describing, Jules, can you tell us, it was a 2-year evaluation, how many patients were included in our data set?
Yeah, so it was 1,700.
Yeah, so 1,700 over 2 years, and this was this like more of, this was a more higher acuity?
It was. Yep, this was a high
Yeah,
acuity population. So about 2 weeks was the average. People
length
weren't
of
being
stay.
looked after. Yeah,
Yeah. I don't know if that fully answers the Q&A question, but I will
Mhm.
say, great question for
Great question.
great
Yeah,
question for AI to answer as well,
yeah,
to get the most accurate
yeah,
information about what the largest scale of these home programs are. But specificity would be pretty important, because I think there's a pretty big skew
yep,
depending on what level of acuity that type
that's
of
right.
program is caring for.
That's right. And in looking, there are two pieces of information that might help in these higher acuity populations. This program that I'm talking about was exceptional in the volume. So we're not seeing a lot of papers with that many patients. There was recently, as a review, I think by Levine, and In that, across Medicaid patients all over the US, they had about 5,000 patients. So that was like pulled from lots of different programs. So I'd say the thousands isn't the norm right now, but probably it's moving that way. Yeah. Okay. Great question. Thanks for that. So once you've got your questions, what are the things you want to think about next? So on our team, and we came together a few years ago, one of our biggest goals as we were setting up was really like, how do we establish our quick wins? Start with your low-hanging fruit. So what can you measure now with the tools you already have, and get that out there either for quality improvement internally, or if you're going more external, even conference abstracts. You don't have to create the world's most rigorous study. You can just start by tracking something that matters.
Ooh,
Even simple questions can guide meaningful improvements. You can choose how formal
I'm
your
gonna
work
need a
is.
little feedback. Is that my internet or Jules's
Oh,
internet? Ooh, mine.
can you? So you
Sorry,
froze for
Jules.
a little while. Yeah, it's always hard to know whose. Think I'm
Mine.
okay to
It was
continue?
mine.
Okay.
Guilty.
You
Guilty.
never
Sorry about
know.
that.
No problem. So you can choose how formal your work is. You can go more internal, as we've said, more quality improvement or full-blown research. Either way, the mindset is the same. You want to ask a question, gather data, and learn something. Just to go back to that full-blown research phrase that I said. So if you want to publish findings externally, or you want to generalize your findings to wider groups, you for sure need to go through an institutional review board. You need to go through an ethical review process. So we always want to keep ethics in the forefront of our work. There are situations that this needs to be formalized through an independent body. So that's just a little flag that those are times. If you're publishing externally, you need research ethics. So other things to think about: who needs to be involved? What does success look like? How are you going to know if your program is successful? What are the measurements, the metrics that are going to let you know that? And when are you measuring? If you want to talk about change, you need at least two data points, right? Kind of a before and an after. And finally, you'll want to think about what's going to demonstrate the most impact. So types of data you can use. We've talked about some of these already. Some of the standards are going to be your clinical outcomes, and you could get familiar really quickly using ChatGPT or Elicit, like what are the clinical outcomes used in hospital at home programs. So things like vitals, your readmission rates, and your length of stay are pretty standard. You can look at your tech engagement. So in any type of intervention, a person's adherence to that program is a big part of understanding what works and what's helping people. So we could argue that if you're not going to use any of the tech that go, even if it's really simple tech like a phone call and taking your temperature with a thermometer and reporting that to a nurse over the phone, it's going to be really hard to run these programs. So the engagement and the adherence is always a good one. And then patient, caregiver, or even healthcare provider feedback. What are the barriers to use? What's working with the program and what isn't? And then operational data like your enrollment rates and adherence. And your AI tools could help here too. So whether you're collecting new or novel data or comparing your data to what's publicly available, you could go in and ask ChatGPT, which we are doing increasingly, are there data sources publicly available that I can compare to? Are there national hospitalization rates for some of these outcome variables that we're interested in, that maybe we could look at and use as a comparison, even if it's not a perfect comparison? It can provide loads of help. These are AI tools with coding and analysis. So this could be everything from more specialized statistics and programming software all the way down to running analyses in Excel. So we're going to talk through some case studies, and Nicole is going to walk us through some of these.
Great. So thank you all for humoring us and letting us share our research with you. We are sharing examples of research we've done in different patient populations using different metrics, et cetera, all to give you a little flavor of the variety of ways that you might be measuring impact of your programs or even the tools that you're using. This example is in immunotherapy. There are actually two examples. There's an example on the left, and that one is really looking at an outpatient CAR T program using our products and services to change the way that patients are receiving this CAR T treatment. And instead of having them remain in the hospital for 16 plus days post infusion, sending them home with some of our monitoring in an outpatient setting. And so this very much is a how to do it and what to expect type of question. It very much is looking at that sort of descriptive element of framing with a little bit of a comparison, although we don't have a comparator group per se. We are using what would have happened as part of standard of care if this program didn't exist. Some of the things that we found is that 17% of those patients went home and never came back to the hospital. The alternative is that they would have been in the hospital for 16 days. Of those who did return, they had a median hospitalization of about 4 days. This is about 75% less than if they were in that standard of care group. Again, it's not a comparator group, but it does allow us to ground our how to do it and what to expect results in a little bit of standard of care realities if this program didn't exist. Now on the right side, that's really creating, this was a more traditional research study actually, and it was a within subjects design. And what that means is that one person was wearing our continuous monitoring wearable while they were receiving standard of care. So these people who participated were in an inpatient setting. The data collected from the wearable was not looked at or used for care, and they received standard of care. So vital signs taken every 4 hours, and the onset of cytokine release syndrome, that's what CRS means, was able to be mapped between, because it's a within person design, between those two ways of collecting the data, we were able to sort of label the continuous monitoring data with it. And then look at if we used, hypothetically, if we used the continuous monitoring data when CRS would have been detected instead. And spoiler alert, or not spoiler alert, it's right there, it would have been detected about 2.5 hours or so earlier than that standard of care measure. And that really builds confidence in our tools that when we're using them in this outpatient setting, like in the example I just gave right before, that they're working the way that we think that they're working. Next slide. This next slide really gives some examples about the way that we look at savings. Yes, we're interested in costs and the cost savings, but there are other elements of savings that you can look at. In the example on the left, it's really looking at time, distance, and capacity. And so this is a postpartum hypertension program where mothers were taking their blood pressure readings at home instead of coming back into the facility to get those readings. And we used, if you can see, there's a little asterisk at the bottom. We made some assumptions about what they would have done if they weren't in this care at home program, as well as how far they would have traveled based on information like their zip code. So these are estimates, but they, again, give us a better idea of what this program is impacting and how much it might be impacting it. Now on the right side, and I bring this up because this is about cost, but one of the things that we did, and one of the reasons I really like this study, and I'll just put a plug out for it, it's a difference in differences analysis. look it up, is it's looking at facilities that have very similar standards of care, although but some of these facilities had a care at home program introduced at a certain time point in there, basically in like the calendar um, year. And so the reason I bring this up is because we looked at the cost savings not just at the program level, but actually at the facility level. So instead of saying, what is the cost savings of this program, we said, what is the cost savings of the facilities that have this care at home program versus the facilities that do not have this care at home program? Again, the difference in differences analysis is a nice natural experiment design. And what we found is that even if patients weren't in the care at home program, there was a savings of about $2,000 per patient at the facilities that had these care at home models. Again, just providing a little bit of variety about how we're doing things, what kinds of metrics we're looking at, and what kind of questions we're asking. Um, before we get into experience, well, not before we get into experience, but I'm going to hand over the experience examples to Jules because she is our resident expert here when it comes to qualitative and mixed method designs.
Great. Thanks, Nicole. So experience can be measured a lot of different ways. This can be more quantitative, like if you are using metrics that have Likert type scale, so strongly disagree to strongly agree is usually a 1 to a 7, and you can use short answer. You can rate things as anything from poor to good. You can also do in-depth interviews if you really want to get an understanding of facilitators and barriers to patients, to caregivers, or to healthcare providers, utilizing, setting up, establishing, continuing to use a program successfully. And there's no one right way. So you just want to think about what's going to give you insight into what's working and what's not. So one area we're seeing a lot more interest in is the caregiver experience, which is pretty essential in hospital at home programs. This often gets overlooked, and even though telemedicine has been around since the 70s, it's really experienced a boom in the last 5-ish years since COVID. So there are a lot of opportunities here for new discoveries around the role of the caregiver in supporting patients that receive care at home. So there are times when you'll want to call in some experts for help and backup. You don't always need a professional researcher, but sometimes it can really help. So where you might want to consider backup is, and we've mentioned this before, if you're publishing externally, if you know you need IRB or ethical review, if you're handling complex data like electronic health record data, if you're scaling up or seeking funding, sometimes making sure your ducks are in a row with the data that you are using to support funding, that can be helpful. And also, if you have any findings that don't quite make sense, or you might need some help interpreting them. A big part of our job as an internal research team with Best Buy Health is to work with our partners, clients, and collaborators to demonstrate their program success. So we've covered a lot of information. I am going to go off screen share now, and we would love to hear from you and get into the chat for questions and comments. Thank you for your attention.
Yeah, so we
Oh,
actually have a question in the Q&A and we have some in the chat. I'm going to go to the Q&A first.
right.
Rich has a question. Can you talk about retrospective research, example, historical data versus prospective? Do you still need IRB consent? You're just data mining. Do you want
The-
to answer this or do you want me to answer this?
Either. I mean, It depends, doesn't it, Nicole? Some retrospective data sources will be available for the public use. This means they will be fully anonymized. There will be zero identifying information. It will be aggregate level data. And these, you just need to cite the data source and you won't need any kind of ethical review. If you're doing chart review for a retrospective study, you definitely need ethical review. Do you want to say more about that, Nicole?
Yeah, what I will say about chart reviews for that retrospective research question is the IRB, the IRB is actually like a pretty reasonable entity. They're really looking at are the things you're doing, whether it's to collect the data or how you use the data of a person, ethical. And so most of the time, and they're also practical about it. So most of the time when you're doing a retrospective study and you're doing a chart review, for example, it's not practicable. That's like a buzzword. It is not practicable to go back and get consent for the charts that you're reviewing. However, if there is like ongoing engagement with these patients, then in fact you might be asked to for consenting in that scenario. Um, However, I've not done a retrospective research study where I've had to go seek consent because it just was not practicable to do so. Does that help answer? I hope that helps answer your question, Rich. Um, Another question from our chat is, do you find AI tools create outputs with hallucinations so you end up having to double check every output for literature reviews? I started typing an answer, so I will give that answer first. So we definitely are only using these tools, especially like illicit, as a first pass and a where to start. I know personally, I then look at what citations they've used and gone to the source citations to read those articles, and again, sort of double check my work, but it's also for me, especially with my intent to publish, to have a deep understanding of some of those details, um, not just for the information I'm seeking at that moment, but also so that I learn something new, whether it's study design, results, or perspectives of ways to think about looking at certain data. So again, I'm probably biased because again, I really like reading journal articles. But again, that's not everybody's thing. We understand
Yeah.
fun for us isn't necessarily fun for everyone.
Yeah. Yeah, I kind of look at this too, because you'll know people that are deeply skeptical of AI tools. And I totally appreciate this. And sometimes my partner will just say, well, you can't trust anything that AI tells you. And I say, well, you have to kind of treat some people like that too. And you just have to check. You just have to make sure that what they're saying checks out. And so I think if there's really low risk and you just want to get a cursory look at something and know a little bit about it, that's one thing. But if you are publishing or you're building a body of work, I think there's no way around going to the original sources. And this is true even of literature reviews, of narrative syntheses, of papers you're reading. You usually have to dig into the original papers eventually, or get a research scientist that loves doing this to do it for you.
Yeah. Thanks.
Okay.
So I think we're at time. And so with respect for everybody's time here, we will wrap it up. Jules, do you have any last words? All to say, we will
Sounds
we will
ominous.
try to answer the questions in the chat afterwards, but
Yeah.
feel free to reach out to us. Danny, can you like post how we can best be reached, maybe in the chat? Um, I'm sure Danny will provide a follow-up as well. Um, yeah. So thank you all
Yeah.
for coming. And Jules, anything to say?
No, thanks. It's been really fun talking to you, and thanks for your questions.
Yeah, have a great afternoon. Bye, everyone.
Bye.